Today we are having a lively discussion. We have got Dr. Seema Das as our examiner, chief examiner. She is from Shroff's Charity Eye Hospital, New Delhi. She completed her medical education from Lady Harding Medical College, following which she did her post-graduation from Maulana Azad Medical College. And later on, she finished her oculoplasty fellowship from LV Prasad Eye Institute. And she is working in Shroff's Charity Hospital since more than 14 years, and currently the director of oculoplasty and oncology services at Shroff Charity Hospital. I welcome Dr. Seema to our KSOS PG classroom. Now I welcome Dr. Leena. She is the mentor for today. She is from Believers Church Medical College, Tiruvalla. And the student who is going to present the case is Dr. Aishwarya Savior. She is a final year PG student and she is going to present today's case. Now over to Dr. Aishwarya. You can just share the screen and start the discussion. Dr. Aishwarya, you're sharing the screen, no? Yeah, okay. You can start. Yeah.
Aishwarya, I think you're muted. Your audio is on, Aishwarya. We can't hear you.
Yeah. Ankit, can you just help her?
Okay, ma'am. Rejoin ചെയ്യേണ്ടത്.
Aishwarya is rejoining, no?
Aishwarya, you can leave the meeting and rejoin again. അപ്പം ശരിയാവുമായിരിക്കും. ഒന്ന് try ചെയ്ത് നോക്കി.
Leena, can you call her and find out what's the problem? Just call her on the phone and.
Yes, sir. Yes, sir.
But it seems her connectivity is very low.
I know.
Yeah, that's what our technical person is telling. She's Wi-Fi only, no?
But her face is quite clear. The video is quite good.
Then actually she can switch off her video and then present.
Uh,
എന്തോ പ്രശ്നം.
Dr. Lena, something is happening.
yes, ma'am. Actually, her audio is not working, I feel. So I'm just asking her to check her microphone, laptop microphone. Just 2 minutes, ma'am. One second. Yes.
She can join to the mobile and present his laptop. Can be while looking the speaker of laptop.
Ma'am, I have asked her to try through her phone again. I don't know. There's some problem with the laptop, maybe.
Yeah, then she can actually, present through phone.
I asked her to do it right now.
Or she can have two logins, like, let her laptop, through the laptop, let her move the slides and through mobile present the, yeah.
Okay. I'll tell her.
Because her slides are moving.
Ma'am, she's trying that method. I told her to log in from laptop and phone.
She's trying, no, laptop.
Yes, ma'am.
സ്ലൈഡ് ഷെയർ ചെയ്യാൻ പറ്റുന്നില്ല.
She has logged in twice.
Ma'am, she's there through her phone also. But അതിലും സൗണ്ട് കേൾക്കുന്നില്ല മാം. അതിലും അതെന്താണ്?
അല്ല, അതിനകത്ത് മൈക്രോഫോൺ അത് എന്തെങ്കിലും സെറ്റിംഗ്സിൽ പ്രോബ്ലം ആയിരിക്കും. ബിക്കോസ് സ്ലൈഡ്സ് ആർ കമ്മിങ് അപ്പ്.
അതെ, ഞാൻ ഓഡിയോ എന്റെ സെറ്റിംഗ്സ് എല്ലാം പറഞ്ഞു, അതൊന്നും ആക്കിയിട്ടും പക്ഷെ കേൾക്കുന്നില്ല.
നേരത്തെ പ്രസന്റ് ചെയ്തിട്ടുള്ളതായിരിക്കുമല്ലോ.
ഉണ്ട് മാം. നമ്മുടെ
അല്ലെങ്കിൽ വേറെ ഏതെങ്കിലും ജോയിൻ ചെയ്യാൻ നോക്കാൻ
അല്ല,
പറ്റുമോ?
ഓഡിയോ ആസച്ച് കുറച്ച് കുറവാണല്ലോ. ഹലോ,
മാമിന്റെ കേൾക്കാം, ഞാൻ പറയുന്നത് കേൾക്കത്തില്ല മാം?
yeah, but audio is feeble. I mean, yeah, I can hear you. പക്ഷെ ഓഡിയോ Whether is there anybody to help her?
മാം ഞാൻ വേറെ PGs-ന്റെ അടുത്ത് പറഞ്ഞിട്ടുണ്ട് മാം. ഞാൻ
Am I audible?
Yeah.
യെസ് ഐശ്വര്യ. Aishwarya, you can share your screen. This is through your phone or laptop?
Yeah. Okay.
I have actually
ഒരു ഡിവൈസിന്റെ പിന്നെ സ്പീക്കർ ഓഫ് ചെയ്യും, സ്പീക്കർ മ്യൂട്ട് ചെയ്യും. ഒന്ന് പറഞ്ഞു നോക്കോ ഐശ്വര്യ ഡോക്ടർ, ഒന്ന് സംസാരിച്ച.
Am I audible?
എക്കോ വരുന്നുണ്ടല്ലോ അവിടെ.
ഐശ്വര്യ, അതെ, രണ്ട് ഡിവൈസിൽ ഏതെങ്കിലും ഒരെണ്ണം മ്യൂട്ട് ചെയ്യണേ.
ഒരു ഡിവൈസിന്റെ സ്പീക്കറും മറ്റേ മൈക്രോഫോണും മ്യൂട്ട് ചെയ്യും.
Now?
Yeah, fine.
കുഴപ്പമില്ല ഐശ്വര്യ.
Yeah. Can start off. I think the audio has gone.
ഐശ്വര്യ.
So, good evening to all. Am I audible?
Audio.
യെസ് ഐശ്വര്യ.
I think she is taking.
ഐശ്വര്യ.
Am I audible now? I think
ഐശ്വര്യ മൈക്രോഫോണും ഓഫ് ചെയ്യണേ ഏതെങ്കിലും ഒരെണ്ണത്തിന്റെ. ഐശ്വര്യ, can you speak?
just a minute.
അല്ലത് echo.
മാം, ഹോസ്റ്റിന് ഏതെങ്കിലും ഒരെണ്ണം മ്യൂട്ട് ചെയ്യാൻ പറ്റത്തില്ലേ മാം? ഐശ്വര്യയുടെ രണ്ടെണ്ണത്തിൽ ഒരെണ്ണം മ്യൂട്ട് ചെയ്ത.
Ankit, can you mute? Which one has to be muted? Laptop has to be muted, no? Yeah, he has already muted one. Okay.
ഐശ്വര്യ പറഞ്ഞു.
അതല്ല, ഐശ്വര്യ ഡോക്ടറുടെ പിന്നെ ലാപ്ടോപ്പിന്റെ സ്പീക്കർ ഓൺ ആണോ? അത് മ്യൂട്ട് ചെയ്യാൻ പറ്റുമോ സ്പീക്കർ?
Okay. Am I audible now?
Yeah.
Am I audible now?
Yes, Aishwarya. There is echo, but
Oh,
speaker mute ചെയ്തതല്ലേ?
Okay, am I audible now?
ഐശ്വര്യ ഇപ്പം വോയിസ് ഏതിന്ന് ഐശ്വര്യ വരുന്നത്? ഫോണിൽ നിന്നല്ലേ? ഫോണിൽ നിന്ന് തന്നെ പ്രസന്റ് ചെയ്യാൻ പറ്റുമെന്നാ? ഫോണിനകത്തില്ലേ ഐശ്വര്യ presentation? അതൊന്ന് ട്രൈ ചെയ്ത് നോക്കിയല്ലേ പിന്നെ?
this is wife.
ഐശ്വര്യ ഐശ്വര്യ സ്പീക്ക്.
I just
She's trying to open from her phone.
open the presentation from the phone.
Phone.
But still, I think echo will come. അത് when two devices ഉള്ളതുകൊണ്ടായിരിക്കും അല്ലേ?
ഉള്ളതായിരിക്കും. അല്ല പിന്നെ ഫോണിൽ ചെയ്യാമെങ്കിൽ ആ ലാപ്ടോപ്പ് അങ്ങ് ഷട്ട് ഡൗൺ ചെയ്യും. അപ്പം
Yeah, okay. But ഫോണിൽ ഷെയർ ചെയ്യാനായിട്ട് she has to say. I hope it is there in her phone.
ഫോണിലുണ്ട്. ഐശ്വര്യ നോക്കിക്കേ, ഷെയർ ചെയ്യാൻ നോക്കിക്കേ.
Yeah, okay. മൊബൈലിന്റെ സ്ക്രീനാ വരുന്നേ.
അതിൽ ഓപ്പൺ ചെയ്യാൻ പറ്റില്ലേ മാം?
ചെയ്യാൻ അങ്കിത് must be knowing എനിക്ക് ഫോണിന്റെ
Yeah, I think.
ഫസ്റ്റ് ഓപ്പൺ ചെയ്യേണ്ടി വരില്ലേ അത്?
Yeah, I think it is. Yeah, it's opened. Yeah.
Okay.
Is it visible?
Yeah, visible. Screen visible.
ഐശ്വര്യ ഒന്ന്
Am I audible?
അതെ.
Yeah, now it is fine. Then you start.
Yes.
Okay. So good evening to all.
Present. Yeah.
I'll be presenting case of a 68-year-old gentleman who presented to the OPD with complaints of double vision and swelling around both. There is no
Yeah. What did you say?
Ma'am, the connectivity of Dr. Aishwarya is very low.
it is not radiating.
Actually, the
Yeah, I
connectivity issue is there. The bandwidth is showing that the bandwidth is
Is
very
it
low. So that's the reason why the voice is breaking.
Okay. So Angan, I think we will. I will ask Dr. Basti, should we cancel it or not? Because with this bandwidth, you cannot present. You know.
Yeah, ma'am. Yeah, ma'am.
Yeah.
There is-
Yeah. Yeah.
Should I try another laptop?
Aishwarya, now we can hear you. Can you just continue? Stand where you have net, no? Aishwarya.
Okay. So there is a dull pain that is worse in the morning hours and on eye movements, and it is not radiating. There is mild redness, irritation, and watering, and problems of the prominence of the eyes did not increase yellowish discharge or decrease in vision. There is no rheumatism or any ocular surroundings. No history of any weight gain, constipation, or cold intolerance. No history of any fever. No history of any cough, expectoration, or breathlessness. No history of any nasal discharge, fullness in the sinuses, or any nasal bleeds. No history of any difficulty in urination, and no history of any swelling anywhere else in the body. There has been no improvement with eye drops that was given by a local eye doctor. So 3 months back, he consulted an eye specialist in an eye hospital, and from where oral penicillin was given, he was not told what the reason for giving penicillin, and the penicillin was given in tapering doses, and along with that, artificial tears was also given. He had only little improvement, hence he was referred here for further management. Now, in the past history, there is history of hypothyroidism in 2000, and he was given thyroxine 50 microgram, and there is history of hyperthyroidism in 2002, and for which he was given carbimazole, and he was given for 3 months. And there is history of hypothyroidism, for which he relapsed back into hyperthyroidism in 2003, for which carbimazole was given for 1 month. And later, he had hypothyroidism again, and for which he was treated with hypothyroxine and 75 mg, 75 micrograms. And yet total thyroidectomy was done in 2017 for multinodal goiter. Now he is currently on thyroxine 150 micrograms. He also has hypertension and dyslipidemia since 2002 and diabetes from November 2021. There is no history of any eye surgeries or laser treatment in the eye or intravitreal injections. No history of similar illness in the past. There is no, in the family history, there is no history of any similar disease in his family. And in personal history, he is currently not working. He is a retired tahsildar and he is a chronic smoker for past 35 years and he stopped smoking 1 month back. Now coming to the general examination, the patient is conscious, oriented in place, time and person, is moderately built and nourished. There is no pallor, icterus, clubbing or cyanosis or bilateral pedal edema, no tremor on stretching out the hands, and there is no dry or scaly skin. In the vitals, the pulse rate is 92 beats per minute. It is regular in rhythm and normal in volume and character. BP is 130 bar 90 millimeters of mercury in right upper arm in sitting position. The respiratory rate is 12 times per minute and his left upright. The systemic examination, the cardiovascular system, respiratory system, the abdomen, and send them to the examination of the neck. There is no thyroid swelling in inspection or palpation. There is no dilated veins or pulsations. No other swellings palpated. The linear horizontal scar of 10 cm was seen in the lower part of the neck, probably the scar of the near total thyroidectomy. There is no carotid brewing. In ocular examination, on inspection, the head posture is erect. The cover tests are oral in primary gaze, and there is no facial asymmetry. Loss of eyebrows are seen laterally, and there is bilateral axial proptosis. There is incomplete and infrequent blinking, giving it a staring look, and there is no visible pulsations. With Lutz exophthalmometer, the right eye measured 23 millimeters and the left eye measured 24 millimeters. Now, moving on to the extraocular movements, there is limitation of adduction, -half in right eye and -1 in left eye, and there's limitation of elevation, -1 in the left eye. The convergence was also seen decreased, and on palpation, there is periorbital fullness, and there is no solid or cystic swelling palpated around the eyeball. The orbital rim had no mass erosions or irregularity. Tenderness was present on palpation. The resistance to retropulsion was absent. The paranasal sinuses had no tenderness or any masses. There was no pulsations palpable. There is no lymph nodes that was palpable. On auscultation, no bruit was heard. The Schimmel's test 1 had 80 millimeters in the right eye and 60 millimeters in the left eye. The Schimmel's test 2 had 10 millimeters in the right eye and 9 millimeters in the left eye. Now moving on to the eye examination. The right eye, the visual acuity aided was 6/9. Near vision was N6. The color vision was normal. Then in the right eye, the periorbital area puffiness was present. There was no visible pulsations, no change in size during Valsalva maneuver or cuff. And in the lids, edema was present. There was difficulty in reversion of the upper eyelid. There was upper eyelid lag on down gaze, and there was lower eyelid lag on up gaze. There was increased lid retraction with visual fixation. There was no lag of thermos. And the conjunctiva, deep injection was also present. Then coming to cornea, cornea was clear on fluorescent staining. Corneal sensations were normal. Anterior chamber had normal depth. It was quiet. The iris had normal color and pattern. The pupils had direct and consensual reflex. There was no RAPD. Now, in the lens, it was image of senile cataract. And IOP that was measured using IK tonometer at 11 a.m. showed 70 millimeters of mercury in the primary gaze and 21 millimeters of mercury in the up gaze. The fundus showed disc color, size all normal. Disc margins well defined. Cup disc stationary with healthy NRR. The vessels are rising normally and branching dichotomously with AV ratio 2:3. The macular FR was dull. The peripheral retina was normal. There was no corroded fault seen. Now coming on to the left type. It was 6/9. Mere vision was center. Color vision was normal. There was no visible pulsation. There was difficulty upper eyelid. There was upper and lower lid diagonally up gaze, certain with visual fixation. Staining was around. The candy brisk, the rapidity, the negative IOP measured using eye care tonometer at 11 a.m. 70 millimeters summer primary gaze and 20 millimeters summer common. Hello?
Aishwarya?
Uh, am I visible?
Yeah, your screen is not sharing.
Screen. Now?
Yeah, continue, Aishwarya.
Can fundus examinations was within normal limits. There was no coral fault seen. Now diplopia charting was done, and it showed on the there was a distance. The two images seen was one above the other, and it was separated, and the separation was more when looking on the left gaze. That is in the liver versions and in the liver elevation and liver depression, it was more, and it decreased when patient was looking into the right side. And the diagnosis is thyroid ophthalmopathy with moderate severity and CSS score 5 out of 7. It was considered to be have moderate severity because the patient had diplopia, and the
Dr.
CSS
Seema,
score
Aishwarya,
is
1
5
second.
because the patient had orbital.
Aishwarya, 1 second.
Okay.
Dr. Seema, you want her to summarize the history? Could you hear her history?
So, Aishwarya, sorry about the difficulties that you are facing sharing a screen. First of all, maybe if it's possible, you might like to rotate your phone, put it in the landscape mode, so it will give you a full screen view of the slides. So just try to rotate your phone. Just rotate your phone. Yes, that's better.
Okay.
So in the history, I think what you have summarized, it's a very detailed history that you have taken, both the ocular as well as the systemic and the general history, as well as both the systemic as well as the ocular evaluation. Now, if we have to highlight maybe 3 most important things in the history, whenever we are dealing with a patient of thyroid eye disease, what will be the 3 most important things, other than, of course, the ocular complaint for which the patient has come to us? If we look at the systemic history, what do you think are the 3 most important things you need to ask in the history, and you need to document and to sort of, take care of those things also?
So we had to ask about the weight loss or any weight gain.
All right.
And about whether the bowel movements, whether the patient has got constipation or any diarrhea. Then the skin of the patient, whether there has been any skin changes.
All right. So when we take the history, it has three main purposes. One is, of course, you are talking about this history you are talking about is aimed towards diagnosing the systemic status. This will give you some idea whether the patient is hypothyroid or hyperthyroid or is it an euthyroid thyroid disease. So that's one part of the history. Second part of the history is, of course, the ocular symptoms, how severe the ocular complaints are, so that you will get some idea when you ask about the symptom onset, any visual complaint the patient has, any recent history of decrease in vision, double vision. Those are going to talk about severity. So in any thyroid disease evaluation, there are three most important things. We need to know the systemic status, whether it's hypo, hyper, or euthyroid, because that is an implication on the eye disease, and simultaneously you have to take care of those while you are taking care of the eye. Second thing is you want to know the severity of the disease, right? So some idea from the history will also give you some clue whether the disease looks to be more severe, seems to be more severe. So these are the leading questions that you would like to ask. The third in the history, which is again very, very important, is to find out if there are any risk factors which is going to affect the severity as well as the activity of thyroid disease. So simultaneously, while you are treating the thyroid, while you are treating the eye disease, you have to take care of the risk factors also, which is going to kind of complete the circle of your management. So what are the three most important risk factors which can worsen the manifestations of thyroid eye disease, which are important to ask in the history?
History of any smoking,
Yes.
then the age of the patient, then the gender of the patient,
Mhm.
then the
Right.
thyroid status of the patient.
Okay. Yeah. So
Uh,
as mentioned, smoking is a very significant risk factor for development of dysthyroid optic neuropathy. It's an universal sort of, sort of seen universally. Those who are smoker, especially the heavy smoker, tend to get more severe disease. So you need to know the history of smoking. And smoking doesn't mean only active smoking. The patient might be just passive smoker. In our part of the country, we do see a lot of patients who, if you just ask, do you smoke? Normally smoking is thought of as just cigarette smoke. That might not be always true. There are other traditional methods like, hookah, um, like, those nicotine, the not the cigarette ones, but the other ones, which tends to be pretty prevalent in the rural setup. Even the females also tend to smoke. So just not the history of cigarette smoking, but any other modality of smoking, any passive smoking also, even if the person might not be smoking himself or herself, but there is somebody in the house adjacent who seems to be a chain smoker, that can also affect. So that history again needs to be, the gutka and the other things, they're all nicotine, they're all tobacco. That history again needs to be put in your case file, and you need to ensure that that is also taken care of. Smoking has to be stopped. If it's a severe disease, then you have to control the disease and prevent it from going into a severe manifestation. Second thing is diabetes mellitus. That's another which is now a known risk factor for causing a very severe systemic manifestations, especially uncontrolled diabetes. So any thyroid eye disease, you have to ensure that the patient is not a diabetic. If he or she is a diabetic, that needs to be under control. If again, if we have to prevent them from going into a severe manifestation. The third thing, which is now known to be a risk factor, which is again kind of, we still don't understand it very well, but there seems to be a very strong association, at least, is active thyroid eye disease and association with sleep apnea. So sleep apnea can have a lot of other systemic manifestation, and it is known to worsen many other ocular diseases, including glaucoma, diabetic retinopathy, and of course the systemic manifestations are there. So any obese patients who has floppy eyelids, who tend to snore, like who has a short neck, these are all the risk factor for sleep apnea. And those who have sleep apnea, especially the severe sleep apnea, tend to get a lot of, again, sort of, severe, more active thyroid eye disease. So that history, again, you might like to elicit, and when you examine the patient, you might like to examine from that point of view also, whether there are any evidence to suggest kind of, sleep apnea or any manifestations. So I think from history point of view, these are the important things, other than, of course, what you have already mentioned in quite detail. Coming on to the examination part, again, you have elicited most of the thing. I just wanted to ask you, when you say the CAS score of 5 out of 7, like, can you enumerate how did you get the score of 5?
So in the first visit, we mainly looked at 7 things. One is spontaneous eye pain or gaze-evoked eye pain. Then the third one is lid edema, then lid erythema. Then there is conjunctival ingestion, chemosis, and inflammation of the carangula. Now all
The face photograph of your patient.
these are the 7 things.
The picture which was there in one slide, just a face picture of your patient before the diagnosis.
Aishwarya, the picture of the face. Go up, no?
Okay.
Go up.
Other way. Go other way.
Up, other way around. Yeah.
Yeah. Just go to the face picture of the patient. Yeah. So maybe somewhere here. No, the one below that. Yes. Just stay there. Yes. Now, looking at this picture, now can you sort of, enumerate when you did the scoring to give a score of 5 out of 7, when you say 5, it has to be, each parameter need to have a score. So which are the parameters where you have given a score of 1?
So in this patient, there was spontaneous eye pain and also gaze-evoked eye pain, and there was lid edema and conjunctival congestion and mild conjunctival.
Can you go to the face picture, because the lid is not completely visible, the single picture that you have? Yeah, just stay there. Just stay there. All right. Now again here, what is the lid edema that you are talking about? Can you point out which part do you think is the edematous?
So if you look at the eyelids, mainly predominantly the lower eyelid is seen more puffy and edematous.
All right. And how would you distinguish this edema from the lower eyelid fat bags? Because in thyroid, we know there is a lot of proliferation of the orbital fat. There is hypertrophy of the orbital fat. Sometimes that can manifest as fat bags in the lower eyelid, where you see those bulge, which are normally also seen in sometimes in elderly patients. Now, how do you distinguish eyelid edema from the bulge because of the herniation of the orbital fat?
These will be a little firm in consistency, and there will be mild erythema associated with it.
Okay.
Whereas if the edema is in consistency and depending on the posture of the patient and the dependency of the edema can change.
All right.
In case of old age.
Yeah. So lower eyelid edema, sometimes, it might be a little difficult to differentiate it from the herniation of the orbital fat. One of the easy way to do it is, we know that orbital fat is going to respect that orbital rim, inferior orbital rim. Generally, that's the limit, because you have the orbitobellar ligament, which limits the herniation. So generally, they will sort of, that swelling or the bulge is going to remain above that line. Sometimes if there is an edema, you see another fistule or another sort of swelling, which is below that line. Normally you have a groove or a depression, which corresponds to the inferior orbital rim. So edema might be present below that line. That herniation will be always above that line. Right? So when you tell the patient to look up, the orbital fat is going to move in direction, whereas the edema is not going to move with the movement of the eye. So that's another way where you can differentiate between the two. Here, of course, I mean, this is just a single photograph, so we can't be very sure whether there is a component of edema also, or this is just a herniation of the orbit. It does look like there seems to be a predominantly herniation of the orbit. Okay. The upper eyelid, again, not very clear from a single photograph, but yes, if it is present, there is edema, obvious edema of the upper eyelid, you will be able to sort of, make it out. So, all right, so you mentioned about pain, you mentioned about edema, which makes it 2 points. What are the other 3?
Aishwarya?
There is mild chemosis of the asthma.
Okay. So chemosis of the conjunctiva, right? Okay. If it is present, then again, that's another sign of activity. You can give 1 point here. So we presume that, again, the picture might not be very clear here, but if it is there, then 1 point goes for that. And that makes it 3. What about the other 2?
There is pain. There
There
is
is?
spontaneous itching. Spontaneous itching.
Yeah, can you speak it? There is?
Spontaneous itching.
Spontaneous eye pain. Yeah, pain we have spoken about. Pain gets 1 point. Hemosis gets 1 point. Edema gets 1 point. And what are the other 2?
One is there is a gaze evoked pain, as well as there is totally 5. One is spontaneous eye pain, then gaze evoked eye pain, then lid edema and mild lid erythema, then congestion of the conjunctiva. These are the 5 things that were seen in this patient.
Okay. So do you think there is a significant congestion of the conjunctiva here in this patient? Whatever is from this picture, seems okay.
There was medially there was more congestion when compared to the temporal part. There was congestion of the conjunctiva.
All right. Okay. A localized medial congestion, you mean? Okay.
Yes, ma'am.
Okay. All right. So, all right, you can go ahead. So, so based on your assessment, it looks like a active thyroid eye disease, right? With a score of 5 out of 7.
Yes. Yes, madam.
Okay. All right. Yeah, you can go ahead.
The patient was said to have moderate to severe thyroid eye disease because the patient had in almost all the cases, and CSS score 5 out of 7 because of the assessment that was done in the first visit. There was spontaneous orbital edema.
Aishwarya?
I think she seems to have got disconnected once again. Possibly again, internet seems to be an issue. If there are any other residents or any other PGs,
Yes, ma'am. We have Namita, Sonia. Please switch on your audio and video. They're not there. Namita? Sonia? Please switch on your audio and video, Sonia. Yeah. Ma'am, there are PGs also, ma'am. Sonia, Namita.
So would you like to, any other resident, would you like to add anything else in the evaluation, which might be important? And else you would like to sort of, put here as part of your evaluation before you go down to further investigation. What is important now? You know a patient. If you have to summarize, this seems to be an elderly, middle-aged gentleman with history of very uncontrolled thyroid status, fluctuating between hypo and hypothyroidism. With a chronic smoker, he's a male patient, and now comes with a history, or now comes with ocular symptoms, and on evaluation, you find that it looks like a moderate to severe thyroid eye disease, right? So what are the other things you would like to chart here in your file before you go down to further evaluation? Specifically, just to kind of, direct the discussion, I'm talking about the natural history of the disease. Would you like to find out the course of the disease for this particular patient, and how do you like to chart it in your files? You must have heard about Rundle's curve, right?
Yes. So
Yeah.
initial space followed by so in the initial phase there is we ask for the progression of the severity of the disease.
Mhm.
And in the active stage we look for the how much active the disease is. And then in the inactive stage, usually it is a quiescent stage. So all of the inflammation will have subsided, and the consequences of the disease like proptosis and all will be remaining.
All right.
So when we ask the history, we can take a history of how it started over time and how each symptom has evolved, and how much has the inflammation reached depending on the edema, erythema, and the symptoms like diplopia and vision, etc.
All right. So it's important to know the course of the disease for a particular patient, because you know that thyroid eye disease has a natural course. It's probably the only autoimmune disease which has a self-limiting course. Even if you don't do anything, eventually the disease is going to die down. The immune system of the body is going to take care of it. Our idea of management is to prevent the disease from going into a severe stage or an active stage, and if it happens, take care of those symptomatic manifestations of the severity and activity. Right. So your patient, it's almost a 20-year-long history. Where do you think on the Rundle curve he is right now? Rundle curves you must have seen. It's almost like a bell-shaped curve where the activity and the severity is plotted against time. As the time increases, with the course of time, the disease tends to die down. So initially you might see it like a peak, and then over a period of time, it will just become a flat curve. Right? So roughly, where do you think your patient is right now? Is he somewhere in
Currently, he is in the active stage.
All right. So is it there somewhere in the peak of the curve, or is it somewhere on the down slope, or the slope which is rising, slope which is falling, or the flat part of the curve?
I think he is in the rising part of the curve because the contracture or the fibrosis has not yet started in the patient. It is
Mhm.
mainly the edema and inflammation that is more preceding and it is more predominant, and the patient has not yet reached on to the peak, I think, because the proptosis and inflammation is not too severe or marked.
All right. So, to know that, it's important to know the ocular symptoms in any thyroid eye disease patients. For your patient, how long has the ocular symptoms been? He must be having thyroid dysfunction for the last 20 years, but for how long the ocular symptoms are?
For the past 10 months.
All right. So,
The
relatively,
patient has been having the ocular symptoms for the past 10 months.
all right. So, relatively short symptoms, ocular symptoms he has. Little unusual because his thyroid has been up and down for the last 20 years, but it's now that he has developed the ocular symptoms. But as you rightly said, if the history is very short and he is showing signs of activity, he is likely to be towards the rising phase of the curve. So now this activity can actually increase further and it can become a sight-threatening disease also, right? Had the history been, say, about 5 years or so or beyond that time, and there were still some signs of activity, we know that possibly he is more towards the kind of, going towards the burnout phase of the disease. And in the, not the rising, but the falling slope of the curve, somewhere there, even if there is a little bit of activity. So why is that information important? Why do you need to know whether he is in the rising phase of the curve or in the other side?
Because if the patient is in the rising phase of the curve, if we can manage it with anti-inflammatory medications like steroids and all, we can prevent it from going into maximum inflammation and causing the complications.
Right. So one is, of course, that it's kind of,
And also
a phase where you can control the inflammation and then prevent the sequelae of the disease. Second is, if at this phase it's already showing activity of 5 out of 7, maybe 2 months down the line or a few weeks down the line, the patient can actually go into a sight-threatening. So you can decide your follow-up schedule based on where the patient is on the Runnels curve. If somebody is already active, seems to be on the rising phase of the curve, probably we would like to keep this patient on a more closer follow-up, sometimes even 2 to 4 weekly follow-up, not like a 3 months or 4 months sort of follow-up, because sometimes they can quickly go into dysthyroid optic neuropathy. Vis-a-vis, if somebody is more towards the other phase of the curve, then you can probably phase out the follow-up schedule also. And because that the symptoms are eventually going down and eventually the disease is going to die down, right? So that information again needs to be captured in your file, the symptom duration. Based on that, you put the patient somewhere into the Runnels curve, and the Runnels curve has to be individualized for each patient. All right? Okay. Please go ahead.
So in the second MRI that is shown, there is marked enlargement of the inferior rectus of the left eye when compared with that of the right eye. And there is also increase in the size of the other muscles of the left eye when compared to the right eye. So the orange arrow mark shows the enlarged inferior rectus. There is the optic nerve is shown more clearly.
Dr. Aishwarya, can you hear me?
So, in
Actually,
the
you are like operating on two devices, I think.
Aishwarya,
they opted more clearly, and you can see that now yes, madam.
Aishwarya, can you hear? She's low.
I think there is some connectivity issues with her, I think, because the weather is very bad now. That's why. I think
The residents who are otherwise connected, if
Yeah.
somebody can elicit
Yes.
the role of, now from here, we have a patient who is diagnosed as moderate to severe thyroid eye disease. Seems like sort of, fluctuating thyroid and seems to be in the rising phase of the Rundle's curve. Now, how would you go about from here? How would you evaluate this patient further? What are the investigations you would like to do, and what management are you going to plan for?
So, for this patient, I would like to. I have done an MRI for this patient that showed marked enlargement of the extraocular muscles, and there has been no signs of any optic nerve compression. And on examination, there has been it has showed a moderate to severe severity of thyroid eye disease. So, according to the Yugogo regimen, I would go for IV methylprednisolone 500 milligrams weekly for 6 weeks, which is followed by 250 milligrams weekly for another 6 weeks.
All right. Okay. So what is the purpose of your imaging? You got an MRI done for this patient. What was the thing? What are the things you wanted to know, and why did you order this imaging? What is the purpose of this?
First one is to differentiate between other causes of proptosis like orbital pseudotumor. So, in Graves of thermopathy, typically you can have enlargement of the belly of the muscle and sparing the tendinous insertions. Whereas in conditions like pseudotumor and IgG4 disease and other inflammatory idiopathic orbital inflammatory diseases, there will be enlargement of the muscle including the tendinous insertions, the inflammation of the belly along with the tendinous insertions. Then I would also like to look into the status of the optic nerve, whether there has been any optic nerve compression, because that also decides the regimen or further treatment. Then the other parameters like how much is the proptosis and all can also be measured in the imaging.
All right. Okay. So by and large, thyroid eye disease is a clinical diagnosis, isn't it? Based on your clinical findings, you have already diagnosed the patient with thyroid eye disease. Yes, you are right. If you have any doubts that whether it could be a pseudotumor, because some of the signs can be overlapping. The signs of inflammation, the pain, sometimes can be sort of, symptoms which are common to both pseudotumor as well as thyroid eye disease. So in those scenarios, yes, it is justified to get an imaging done to differentiate between the two entities, because the pattern of involvement of the muscle is going to be a little different in pseudotumor vis-a-vis thyroid eye disease. All right. But are you aware of the clinical criteria which is used for diagnosis of thyroid eye disease? Generally, imaging we don't do to diagnose thyroid eye disease. As you rightly mentioned, imaging is mainly to rule out other entities. That's one indication. Second is if we are planning any surgery for this patient, before the surgery, we would like to get an imaging because you would like to plan your surgery. Otherwise, it's usually clinical diagnosis. So what is the clinical criteria based on that which you sort of, diagnose thyroid eye disease? I mean, it could be any other resident who would like to answer. Are you aware of any clinical criteria?
Yes, there are other criteria like the visa criteria, then DCAS classification is for the severity. Then there is a UGOGO regimen for the classification into mild, moderate, and severe. Then
okay. Okay. So these are basically, once you have diagnosed the patient as thyroid eye disease, this criteria, we are going to tell you what is the activity and the severity of thyroid eye disease. But generally for thyroid eye disease, there are clinical criteria which are given by Bartley and Gorman. These are called as the Bartley and the Gorman criteria. You can pull out the paper and read about it. It's a little old paper. And there are certain clinical criteria based on the presence or absence of eyelid retraction, which is supposed to be a very specific finding for thyroid eye disease, and the kind of, systemic thyroid status. So based on those combination, you can have a clinical criteria where even if you don't have any imaging or anything else, the patient fits into those criteria, you can diagnose it as thyroid eye disease. So maybe as resident, you might like to know about that criteria and read up those articles. It's called the Bartley and the Gorman criteria. All right? Okay.
Okay.
So, yeah. So then you have done an imaging. How do you go about now managing this patient? You mentioned about the role of steroid, right?
Yes, ma'am.
Okay. So what is the purpose of your, why do you want to give steroid to this patient?
Steroids are done to reduce the inflammatory component of the eye. So in the pathogenesis, it is a large number of inflammatory reaction occurs in the orbit. So there is a lot of interleukins, prostaglandins, and inflammatory cells like plasma cells, B cells, and T cells. All are involved in the pathogenesis of the disease. So when you give steroids, the inflammation of the eye will decrease. So as a result of which, the symptoms and all will symptoms will decrease, and the progression to sight-threatening condition will be decreased.
All right. So the purpose of giving steroid for a moderate to severe, you are aware about the UGOGO classification, right? How do you classify into mild, moderate to severe, and sight-threatening? These are usually the three categories. All right. So if it falls into moderate to severe, yes, as per the UGOGO protocol, you can use the low dose protocol here with the idea that you want to prevent the sequelae of the disease, which sometimes can become permanent, like muscle fibrosis, diplopia sometimes can become permanent, needing additional surgery if you do not control it in the activities. All right. Sometimes even if there are no diplopia, muscle fibrosis, but the disease is moderate to severe, which is hampering with the quality of life of the patient. The patient is symptomatic. That could also be an indication for treating the patient with steroid, right? So before treating the patient, you have to ensure that, of course, there are no contraindication to steroid, because when you talk about steroid, what kind of steroid are we talking
about? Normally, for moderate to severe severity, we give methylprednisolone 500 milligrams weekly for 6 weeks, followed by 250 milligrams weekly for another 6 weeks.
Okay. And what are the things you are going to check before giving the patient steroid?
The blood sugars, the pressures, and these two are the most important ones. Then any other complications of steroids like glaucoma or cataract, all of these conditions has to be checked.
All right. So systemic indication or systemic contraindication, ocular contraindication, preferably it should be given under the supervision of a physician with adequate workup of the patient. Specifically, if there are high risk factors like, if the patient is diabetic or any cardiac problem, any hepatic problem, because those can get worsened with use of high dose steroids, right? Now, suppose this patient had an activity of say 3 instead of 5, mildly active disease. How do you treat this?
We treat the symptoms of the patients by giving artificial tears or lubricant ointments. Then we can also give if there is any discomfort to the patient, that has to be decreased. So if there is lag of thermos, then you can do the lateral tarsorrhaphy. And so it is mainly the systemic management of the symptomatic management of the symptoms that is done in mild case.
Right. So important thing to note here is that not all activity needs to be treated with steroid, right? So steroid has a role only if the disease is active. That too when the activity is, because anyway a score of less than 3 is not considered an active disease, right? So if there is no active disease, there is no role of steroid. Then there is role of other symptomatic treatment or other rehabilitative treatment. Steroid comes into the picture only if there is, like the signs you have enumerated, the CAS score, only if those are there, then only we give steroid. How much steroid to give, what route to use, depends on how active and how severe is the activity. Activity can be mildly active, can be severely active. If it is severely active disease, which is maybe threatening your vision, causing an optic neuropathy, then you have to sometimes go for a high dose IV methylprednisolone also, which is again given by the UGOGO protocol. There is a low dose regime, there is a high dose regime, right? So all those things are given. It's a very nice paper. I think all of you should read that paper, the UGOGO consensus criteria, published in 2021, I think. And it gives very beautifully the stepwise management of thyroid disease, right? Okay. Any other than steroid, what are the other kind of modalities which also simultaneously we need to?
So you can also go for immunomodulators, like
one part is the medical part of it, right? One part is just treating the activity part. What are the other things you have to be you have to take care simultaneously while you are treating the activity?
Systemically, the patient, the diabetes has to be controlled, hypertension has to be controlled, the patient has to be asked to stop smoking. Then the thyroid status of the patient should also be brought under control.
All right. So these are very, very important things. Unless you bring the thyroid under control, whatever treatment you give might not be very effective, right? Because our whole purpose is we are treating the natural history of the disease. We are not changing the course of the disease. The disease anyway is going to take its own course and die down over a period of time. We are only treating the severe manifestations of the disease, preventing it from becoming severe and causing a permanent sequelae, right? So simultaneously, you have to ensure that the thyroid comes under control quickly. If the patient is hypo, that's also not good. If the patient is hyper, that's also not good. It has to be euthyroid. So your endocrinologist, you have to tie up with an endocrinologist, ensure that adequate consult is taken, and then simultaneously the thyroid is taken. That's one. The risk factors that we have spoken earlier in the history, all the risk factors we should try to minimize as much as possible, which includes number one, smoking. Especially if it's a male patient, they get very bad disease, very quickly can go to dysthyroid optic neuropathy if they are very chronic smokers. So that has to be stopped. Diabetes has to be under control if that is there. Hypertension, of course, and hypercholesterolemia also is now supposed to be kind of worsen the disease. So all the systemic manifestations. And if somebody has sleep apnea, that also needs to be taken care of. So you take care of those also simultaneously while you are taking care of the eye disease, right? So now coming back to the eye disease, other than steroid, what are the other things which you need to also think of while you are managing the eye disease, which you might need depending on the severity of the disease?
So if it is a sight-threatening case, we should consider the orbital decompression. And if the patient is not responding to steroids or is contraindicated to steroids, you can consider immunomodulators like rituximab, adalimumab, the methotrexate.
Now comes the question, what is the indication of surgical intervention in an active disease?
So if it is an active case, with the then if it is side threatening is the indication for orbital decompression. That is
All threatening neuropathy or sight-threatening eye disease. If suppose the patient at presentation has sight-threatening thyroid eye disease. So sight-threatening can be in two ways. What are the two ways patient can have a sight-threatening disease?
Can be exposure keratopathy or optic nerve compression.
Right. So how are you going to manage the two?
Exposure keratopathy, in both the cases, you have to decompress the orbit so that the optic nerve compression is decreased. Then in exposure keratopathy, it can be treated with bandage contact lenses, then lubricants, and then followed by orbital decompression. So initially.
So then what you have to understand is like, vision can be affected in thyroid either posteriorly because of the optic nerve compression or anteriorly because of corneal compression, right? Optic nerve compression is generally it usually will happen in the active phase of the disease when there is too much of congestion in the orbit, the muscles are very bulky, and there is crowding of the orbital apex. So that's one of the indication where sometimes you get an imaging done to see the orbital apex. If the muscle bellies are so bulky that is pressing the nerve at the orbital apex, right? That's the narrowest area, all right? So in that case, of course, you need to, if it's because of inflammation mediated, you need to take care of the inflammation. So the first step in dysthyroid optic neuropathy again remains steroid. Surgery is not the first line treatment for dysthyroid optic neuropathy. We first give a trial of steroid. Here we go for a high dose steroid. Instead of the low dose protocol, we go for the high dose protocol, right? More aggressive. If that brings the things under control, then of course, fine. If that does not bring the thing under control, because steroids are the most effective treatment, patient still continues to lose his vision or maybe visual field. One thing which I think in the evaluation is important is to also get a baseline visual field. If the patient continues to lose the visual field or the vision itself is going down, color vision is getting affected, then there is a case for going for an emergency orbital decompression. Right? Generally, we go for a medial wall decompression because the idea is just to release the pressure on the optic nerve. Just open up the posterior ethmoid, let the things herniate into the ethmoid sinus so that the pressure on the optic nerve is released. All right. And it can be done very well by the endoscopy. The second way where the sight can be threatened is because of corneal exposure. Now, corneal exposure, it's not necessary. It will always happen in the active phase of the disease. It can happen if the proptosis is so severe that the cornea is getting exposed, right? In that case, again, your treatment remains based on whether this proptosis is because of the active disease or it is a burnt out disease but with a residual. Both the things can happen. If the disease's activity is already gone, but the proptosis has remained with a lot of lag of thalamus because of the scarring of the LPS and the other muscle, the eye does not close completely, but there is no sign of activity. There is no lid edema, erythema, or the other sign, but the eye just doesn't close. There is a severe lag of thalamus, and this is causing a corneal compromise. So here again, giving steroid might not help. Here, what you need to do is to now close this eye. So you can close it by either doing a tarsorrhaphy as a temporary measure. You can take care of the lid retraction, right? Let the eyelid fall down. Or if the proptosis is the main cause, which is mechanically causing exposure of the cornea because the eyeball is too much out, then there is a case of doing a decompression to put the eyeball inside. The purpose of decompression here is different than what we are doing it for thyroid optic. All right. So corneal exposure can happen both in the active phase as well as the inactive phase, whereas dysthyroid neuropathy is usually a manifestation of the active disease. So based on that, you decide on it. Okay. All right. Dr. Lina, I don't know how much time, Dr. Marian, what is the time limit? So you can please stop.
It's almost 9:30 now.
I think it's
slowly. I think we will wind up. And Dr. Seema, anything you would like to add? Done.
I think the resident purpose, this much is once you should know, the algorithm, the evaluation has to be very kind of, sort of crisp. What are the important things in the history? What are the important things in the examination, which you need to focus on? And the purpose of evaluation has to be very, very clear. We are evaluating this patient from 3 points. One is from the systemic status, one is from the eye disease, one is from the risk factor, which is going to worsen the eye disease. All these things needs to be taken care of both in the history as well as in the examination. And once you know these things, your management.
Dr. Leena, anything? Yeah.
Yeah, Dr. Seema, I think you were saying you completed, ma'am?
No, so that's it. Yeah, that's it.
Okay. Yeah, ma'am, you have completed almost all the important parts required for our PGs. It was definitely a very nice class. I do not think there's too much more I have to add. All the important points have been dealt with, ma'am. Thank you so much. I think, ma'am, I think
Yes,
rest
I think we will.
treatment is also done, PGs in what they require. So I don't think there's anything more to add. So,
Okay, so thank you all. We have come to the end of this session. Dr. Seema, thank you so much. It was very nice. Even it was really like very informative for me also. Some of the things like, and thyroid eye disease, it's a very huge topic. You can discuss each and every aspect in a day. I mean, it's a lot to discuss. For the postgraduate point of view, I think we have covered everything. It was very nice, very wonderful class and very informative too. I'm extremely sorry for initial few 20 minutes technical glitches.
we are sorry too, ma'am. She was managing with her mobile data. So hopefully next time we do a presentation, we'll do it from our hospital Wi-Fi, from a boardroom or something.
It's going on cyclone and the other things, which is
Yeah, it was rainy. I think, yeah. No, she was confident about her internet. It was 5G and all, but I think it's the climate outside. It's raining, so maybe hopefully next time.
She presented very well.
Thank
She mentored very well, very detailed presentation.
So thank you once. Thank you, Dr. Leena, Dr. Seema, and everybody. Dr. Sadish, Professor, Head of the Department of Believers Church Medical College, for agreeing to present in this PG classroom, and PG student Aishwarya also. So we will good night to all of you. Thank you so much.
Good night. Thank you, ma'am. Thank you, Dr. Singh.
Okay, bye.